All right, it's noon here exactly. I am Dr. Tano. Today we're going to have a talk from Dr. Mekonnen on insomnia with a focus of insomnia um, in COVID. And it looks like there's about 50 people tuned in. So I'm going to give people a few more minutes just to sign in because I think we might get a few people in the next few minutes that are coming. But let me just say that couple things. So if you are not muted, please mute. Um, and sorry, I'm getting messages from people, so I'm reading them as I'm going from people. So if you're not muted, please mute. This session is recorded, so if you have any specific questions that you want read out, we're happy to answer them, but just know that your question might be include anything you don't want to include. And then feel free to use the chat to ask questions. Dr. Mekonnen said he's going to talk for about 15 minutes or so and then take questions from the audience, and those are always fun. I would prefer if you would use the question answer tab. That's a little bit easier for me to see questions as they come in. Those are anonymous to the other viewers. They cannot see those questions. Only I can see those and the other panelists. The chat, it can be seen by everyone if you don't specify privacy settings. So please use those to ask your questions, but let's give people another few minutes because about 10 more people signed in this time that I was talking. But while you guys are all listening, let me just give a little plug. We're doing these webinars most Monday, Wednesday, Fridays. We're trying to get them pulled together for people. Next Monday, the May 4th, is the COVID update number 2 with Dr. Tannenholz and Christina Schrack, who's one of our nurse practitioners. The two of them are on our COVID task force, and they've been doing a great job of keeping our practice up to date with health department guidelines and getting our lab in order and all of that. So they're going to talk about updates in the practice with COVID, but also in the community. I've asked them to address a lot of the patient questions around the DNA testing and then also the new antibody testing that there's a lot out there in the media about. So if you, Monday should be a really good lecture. So if you have time on Monday, definitely tune in. It will also be recorded and posted on our website. If you have questions, you can always look at it later. And then next week, also Wednesday, El Shadday, who's one of our nurse practitioners, is going to talk about cholesterol and treatment. And then next Friday, Dr. Ketan, and he's going to be joined by two of our new doctors, Dr. Christina Council and Dr. Karia Holmes, are going to talk about virtual visits. Virtual visits about how to prepare for one, how to go about scheduling, how to do all that, and what to expect. The nice thing about this lecture, it's being given by not only Dr. Ketan, but two of our new doctors. So if you are missing a doctor in the practice, maybe you had Dr. Kellogg and she retired, maybe you have Dr. Silverman and he's planning to retire at the end of this year, or if you have been working with Dr. Liu and she has been out, or if you were working with Dr. Sterowitz who has reduced her panel size, that might be a nice lecture to listen to just so you can see the other two of our new doctors and see if they're a personality that you think you might get along with. So that's always nice. But let's go ahead. Again, I'm Dr. Tana. I'm one of the primary care doctors. I am organizing these webinars. So let's get started. Today we have Dr. Mekonnen. He is one of our he is our sleep medicine specialist. He is trained in pulmonology as well with further training in sleep medicine, and he's going to talk today about insomnia. And hopefully he'll touch a little bit on our sleep lab too, because that's a really cool part of our practice that if you have not had a sleep study, you probably didn't even know that we have in our office 4 rooms that actually look exactly like hotel rooms, and they are very neat. So without any further delay, Dr. Mekonnen, go ahead and get started. And to participants, please submit questions as we go, and then we'll get to as many of them at the end as we can. So thank you.
Thank you. How's the volume? The voice is good?
Yep, I think you're good.
Okay, excellent.
Actually,
So
you're not in the middle of the screen, actually. You're a little down in the corner. Oh, that's better. Perfect.
okay. So thank you for joining the call. So what we will be talking about in the next 15 minutes, and our open forum for discussion would be on why talk about sleep at this point. In general, we know sleep, good sleep, is the time where our body gets restorative function. What I mean by that is the body accumulates different type of toxins to the brain during the daytime as a byproduct of our daily activity and energy use. And the brain clears those during sleep time when we are sleeping. Sleep is a dynamic process. There are lots of changes that happen. And as the night goes on, we all go through different states of sleep. And it's critical that we get the different percentage and the sequence of sleep, what we call the sleep hypnogram, looks normal to maintain a good daytime function and good health. In particular, sleep has been shown to have immune modulating function. Experiments done in viral infections. These are normal young adults with no problems who have been recruited and who have been exposed to a rhinovirus. A rhinovirus is the virus that causes common cold. And the group was split into two to see if the duration of sleep actually affects whether the person gets infected by the virus, but also whether they develop clinical disease or common cold symptoms. So the two groups, those who slept 7 hours prior to having exposure to the virus, and this was done in a 7-day run, and it was objectively measured beyond personal report by objective measurement of sleep, did well even though they were exposed to the virus. They did not develop common cold more than the usual incidence. But those who slept less than 6 hours had a very high odds of developing common cold symptoms. Especially if the sleep duration was shortened to 5 hours, the chance of developing common cold, both having the virus settle down in the upper respiratory tract and also manifesting symptoms. And the way the studies were done was so objective. The viral cultures were taken, mucus production was quantified. So in a clear clinical development, actually was 4 times higher than those who slept 7 hours. The duration of sleep was the strongest predictor as to why we get viral infection like common cold and how we manifest the clinical symptoms. Number 2, sleep is where our immune system tries to take the cells that we need to the sites where the body fights infection. What I mean by that is as we sleep at the beginning of the night, the blood is flooded by cells, that T cells and helper cells that help the immune system. As the sleep progresses, these cells go and migrate to the lymphatic system. These are glands that would fight infection. If sleep is curtailed, if you shorten sleep, and if you take blood sample from someone, you can clearly see the immune function going in a wrong direction. Cells that we call killer cells, cells that would kill an outside invading bacterial or viral or tumors for that matter, would have reduction in function when you shorten sleep. At the same time, substances that favor inflammation would be secreted at a much higher level when you shorten sleep. This holds true or acute shortening of sleep, sleep deprivation in a short term, or what we call cumulative sleep deprivation. To take it more further, let's say somebody is exposed to a viral infection. Does sleep help in terms of developing an antibody, a response of our body that will subsequently protect us? And yes, normal sleep helps for that. This was proven with a study that followed people who got hepatitis B vaccine. Hepatitis B vaccine was given the usual regimen, the 3 doses. Currently, some other dosing regimens, but people were followed 6 months after if they developed protective antibody and what was their sleep quality by the time they were getting the vaccine, which means if someone is going to get vaccinated, look back 7 days, including the day before, if they get 7 hours of sleep, normal sleep, 6 months after the study, their body responded by having a high level of protective antibody. While those who slept less than 6 hours, the antibody response was much lower level. So if you get a viral infection, obviously you would like to heal from that, but also you would like the body to have downstream protective antibody formation. Even though you cannot generalize this to the current coronavirus, but previous studies have shown that A, short sleep predisposes the body to get viral infection. 2, normal sleep is protective. And 3, normal sleep helps the body immune function in favor of protecting us. Or short sleep has been shown to predispose our body to inflammatory conditions and to have the immune function dysregulated, not favoring our body. But also, normal sleep shows it helps us to protect our body to mount the appropriate immune response so we develop protective antibody. Now, with the current situation, everybody's mostly home. There are quarantines, so life is different. But also, there's a lot of negative news circulating, rightly so, as a result of what we're facing. When people are home now, the use of social media, the use of light exposure, particularly close to bedtime, is high, and you can see this even in consumer reports, like Netflix doubling its consumer base in a very short period of time. It tells you that people are tuned into this. But nighttime, when we expose ourselves to light, we are making the body produce less melatonin. Melatonin is a hormone that we need close to bedtime for the hormone to rise up. It's a dim light hormone. When we dim light, our melatonin level goes up. Melatonin helps us get to sleep, but also helps us maintain sleep. We're sitting and exposing ourselves to light. The melatonin level goes down. Number one, sleep will be poor, but also melatonin has been shown to have a function far beyond sleep cycle regulation. It is an antioxidant. It's an anti-inflammatory. It protects blood vessel cells. This has been seen in other viral infections, particularly during the Ebola epidemic. Melatonin was given as an adjunct treatment. It's been shown to reduce the severe form of the disease. Basically, people going into shock was significantly helped by administration of melatonin. The current coronavirus, as you know, dysregulated in our immune system, so the body gets more attack than protection. It affects blood vessels, as studies have shown, multiple blood clots in the lungs and other parts, and even stroke and otherwise young people. So even though there is no direct study that has been done, melatonin helping, we're There's one paper that's proposed to see melatonin as an adjunct therapy, very respected journal. But instinctively, because it's a hormone within our body, because it's a hormone that we should have, because it helps our sleep and progression, we can help the body produce melatonin by staying away from the screen close to bedtime, by dimming light. In addition, our wake-up time gets affected when we're home and our schedules are loose. The sleep-wake cycle is critically important for secretion of hormones that favor the body's immune system, particularly cortisol. So my suggestion would be for all of us who are staying home or even in everyday life, one, we have to keep a fixed wake-up time. We have to make it a routine. As soon as we wake up, we would like to attain a full awakening. The way we do that is by having bright light exposure in the morning, by having a physical activity in the morning, which would include 5-10 minutes of gross motor movement, jogging, stretching. Gross motor movement activates the body to emit its system, what we call reticular activating system. There are neuronal networks that goes to the brain cortex that makes us fully awake and alert. So fixed wake-up time, bright light in the morning, physical activity. And as the day goes on, as much as possible, we should stay awake and alert. But, if a nap is needed, be close to 1 hour, 2 hours after lunch for a shorter period, 15 minutes to a max half hour of nap. It's okay, but no napping in the late afternoon to affect nighttime sleep. So I think, and reducing stressful things, nighttime, of course, you get the news and you filter what's important and what's good, but try to avoid negative news. If not, implement relaxation methods. I strongly suggest doing meditation or yoga or deep breathing exercise under dim light, half hour prior to bedtime. All of us should shoot for 7+ hours of sleep and protect the body from helping itself mount the right immune system. So with this, I'll open the floor for questions related to what we talked about or otherwise. You can feel free to ask me questions related to sleep in general.
Yeah, so it's Dr. Mekonnen, it's a little hard to hear you. I've asked Travis if maybe there's some suggestions he has. I don't know if it's your mic or if maybe you're just a little close to it. I'm not sure, but let's just continue and we'll do our. People didn't hear something, just let me know and I can try to have you repeat it. Okay, so you talked about melatonin, exercise, not eating too much. Those are all great. I'm getting some questions about the dosing of melatonin. How much melatonin should people be taking?
So the first thing is, I was not suggesting external melatonin. What I said was for the body to help its own melatonin to rise up. Our body has melatonin in its own, but the activities that we do is what's cutting down melatonin, and that's particularly light exposure. So if we have dim light for about half hour before bedtime, if we avoid screen time, then the body has its melatonin that mounts up. So the first thing to do would be to correct behavior with things like that. Studies on melatonin for viral infections were much higher dose. This was under Ebola at the time, but usually we use melatonin at a very tiny dose, 1 milligram, 2 milligram, 3 milligram. I wouldn't go way up that. But the first thing to do is not to take external melatonin, but rather to do the behaviors that would help the body mount its own melatonin.
Okay, and if somebody is taking melatonin at home, how much would you recommend that they do take if they take it before bed?
So for sleep, 1 to 3 milligrams is enough.
Okay, and how far in advance of bedtime would you recommend that?
About 15 minutes to half hour is fine.
Okay. Question here, in your experience, is a Fitbit accurate for measuring the stages of sleep? I know you have some fancy sleep tools, so how do you think the Fitbit stacks up?
So Fitbit is a motion sensor. It's a crude measurement. It's good for sleep and wake, but not to stage each stage of sleep. When we monitor sleep with our what we call sleep profiler, it's a real-time brain EEG, brain electrical wave movement that would give us the breakdown of REM sleep, stage 3 sleep, and also tells us if the brain is waking up because of what we call cortical awakening, which means if you're anxious, there's a different type of brain wave that comes up. Reduction or incremental pulse gets correlated with that. So that's a crude measurement. It's better than subjectively trying to quantify sleep. But the most objective, if there is sleep fragmentation, is what we do here, what we do a sleep profile, and usually we do 2 nights in a home sleep.
Okay. I've had a few questions actually about people who wake up in the middle of the night, and if you have any tips of how they can get back to sleep.
Yes, so that's what we call insomnia. Insomnia could be getting to sleep or maintaining sleep or waking up early, or it could be all of the above. And sometimes in a person, it fluctuates. When there is middle of the night awakening, the first thing that we do is we go through detailed history to see if this is a physiological reason. Physiological reasons for sleep fragmentation, like is this airflow obstruction? Is this an apnea? Is this restless leg? Is this periodic body movement? Is this asthma? Is this reflux? Or a combination of things? Then we will also look at, is this more of the brain function, like what I described like cortical or psychophysiological insomnia? So the first thing is we try to tease out why that's happening. And we objectively measure this by home monitoring. After that, we put on a plan depending on our finding. Treatments could range from what we call cognitive behavioral approach, sleep restriction, it can involve sleep medication use, or it could involve treating the underlying reason. So those are the kind of things that I would suggest we need to, in detail, talk about it and review each individual case and come up with a plan.
So some, all right, sorry, we just have a lot of questions coming, trying to group them together as they come. So do you have any suggestions for managing COVID dreams? So anxiety and stress dreams. So maybe this is similar to the people who are waking up, sort of, but a little different. Dr. Mekonnen, we can't hear you at all. Something cut out with your mic. Did you hit mute? No, can't hear you.
No?
Can you hear him now?
Oh yeah, I can hear him now. Yeah, how's that?
You can hear me now. Okay.
Oh, I think that's much better. Change the mic.
Okay, Travis worked on it, yes.
Okay, yes, all right, because I'm getting a lot of comments from people having trouble hearing. Yes, that sounds.
Okay, so in the time of crisis like this, even when pandemics like this come, like during the AIDS time, the disease is there, but there's also hysteria about it. Rightly so, because this is a very uncertain time. So the anxiety, the fear, the having the negative, thoughts disrupt sleep. We know all this. So the first thing to do here is to be very realistic. Cognitive approach of sleep management means to get the facts right. We do know, we have information now what COVID does, how it gets transmitted, what are the symptoms. Beyond that, we should not internalize things so that nighttime it almost surfaces out and fragments our sleep. So first thing is to really have an understanding about the disease process and what can be done and what the outcomes are. The majority of about 80% of this being passing without much of a problem. So negative thoughts have to be avoided. Number two is really trying to what we call sleep dream displacement. Dream displacements are used under negative circumstances like combat, bad experiences. What they are is if you close to bedtime, if you rehearse good thinking, think of the best vacation you have, think of the flower garden that you have visited, and repeatedly think about these things in a cyclic way. Dreams are repressed thoughts that surface at nighttime. So you can help your negative thoughts get displaced by positive thinking. So I would suggest, even if we don't have the bad dreams, close the bedtime to think of the good, the pleasurable things in a repeated way. Because the brain force during REM sleep and it surfaces out to blank and surfaces to this. So that's what I would suggest.
Okay, so just to summarize a little bit for a few words that cut out. So you're saying avoid the negative thoughts as much as you can. I assume that would also mean don't read anything negative right before bed. Don't read your phone or watch TV with negative news. And then as far as coming up with the positive thoughts, do you mean during the day or do you mean telling yourself positive thoughts in the half hour or so leading up to bed? Where do you recommend those?
In dream displacement, the best if you do it close to bedtime. If you think of this, but you have to do that repeatedly. So those would be the dominant thoughts that would surface and displace the negative ones.
Okay. Just a question here. A patient said the American College of Physicians put out a clinical guidance that says over-the-counter melatonin is not very effective for chronic insomnia. That could be a whole different talk, chronic insomnia, but do you have any thoughts on melatonin for more chronic issues?
Yeah, so melatonin is not approved for insomnia by FDA or there's no clinical use. It's used in everyday life based on just common knowledge. But it's not my go-to medication for insomnia. I raised it in this case because of its other functions. When there's chronic insomnia, again, like I said, the first thing is we'll clinically evaluate what's going on. We'll objectively measure and see. And the first thing we implement is what we call cognitive behavioral approach or therapy after objective testing. If we have to go to medication, we go to FDA-approved medications. The medications like Ambien or Nesta, like those kind of medications, but not melatonin. It's not the way to go for that reason. But in chronic insomnia, still dimming light close to bedtime helps your own body raise melatonin.
Actually, so Dr. Park, who's one of our clinical psychologists, submitted a question. She said she gets a lot of questions about CBD, medical marijuana, and CBD oil. Opinions on that for sleep?
Yeah, so CBD is not approved or endorsed by our community for insomnia, but you'll hear people coming, and I have patients who come and say either they're using the oil or doing this and the sleep is better. So my take there is if they have additional like chronic pain issue, if with the use of that we're reducing narcotic use and at the same time helps the pain, my clinical judgment would be okay to what you're doing now. But as a first line, again, I said I would not use it. The behavioral approach after measurement in insomnia, especially short term, has an 80 to 90% success rate without medication. But it's also a tool that you will learn for the rest of your life. So no side effect, has great success rate, but it has to be implemented after objective measurement of sleep. So you don't want to implement this if the person has less than 6 hours of sleep. Then, we start with medication first. But if it's more, but it's fragmented, or they're not getting to the different states, is when we go into this, phased approach of cognitive behavioral therapy.
Okay. So when you first were talking, you talked a little bit about what I guess we would call sleep hygiene. So techniques to get your brain in a place of falling asleep. So a patient here has questions about some specifics of how long before bedtime to start dimming lights and how long to avoid TV and screens. Yeah.
So look at the day in 24 hours. In sleep biology, it's circadian. It's, when we look at a person, we look at 24 hours. So the first thing is the morning wake up time. Make it fixed. As soon as you wake up out of bed, you do bright light. And when I say bright light, it's really good intensity light, especially we're indoor now. We really have to open windows, have bright light, and do physical exercise. You stay awake as much as you can throughout the day. If you have to take a nap, right after lunch, half hour at the most. Nighttime, because we're shooting for 7+ hours of sleep, let's say if my wake up time in the morning is at 7, the latest I have to go to bed would be midnight, so I can have 7 hours of sleep. Nighttime, if you dim light for half hour, we're going to bed. Within that half hour, if you do something that calms you down, for one person it could be a light music, for one person it could be deep breathing, it could be meditation, it could be yoga, and it could be some of the pleasurable things that we talk about without stimulation and without light exposure. And if you do this routinely, the sleep center in the brain is trainable. And it's trainable, it's like a pacemaker, like the heart beats or breathing is in and out. The sleep cycle could be trained in a way that it maintains this 24-hour cycle.
Question here about somebody who has to wake, which this is like everybody, somebody who has to wake up at night to empty their bladder. Sometimes it takes me a few hours to go back to sleep. Would it help if 1, I drink less water during the day, 2, eat more salty snacks? I guess what would you suggest for somebody who's waking up to urinate?
So a couple of things here. When nighttime bathroom visits, we call it nocturia, is the reason for fragmentation of sleep. Number 1, in 25% of cases with nocturia, both in men and women, it's possible there could be a condition called sleep disorder of breathing or sleep apnea as a factor, either as a sole factor or making the reason why we go to the bathroom more frequently. So first pass is we will do screening questions for is there apnea or no apnea, because if there's apnea, body produces a hormone that would make us produce more urine, and it would make us go to the bathroom often. And if there's apnea, we treat that. We see nighttime bathroom visits go down, sometimes even eliminate if that's the sole cause. So that's one. And number 2 is, yes, you mentioned less fluid intake post bedtime, that helps. Salt is the other way around. Not too salty food, but less of a salt, so that the water demand is not high. Those are things that we will do. But in general, if we evaluate the overall sleep, if the reasons for sleep fragmentation also goes down, we see bathroom visits going down as well, beyond the urological or gynecological issues.
Interesting. So I guess you had mentioned that apnea can contribute to waking up at night to urinate, and I've had a few questions about who is appropriate for a sleep study, and then this is maybe a little bit not totally COVID insomnia related, but questions about the benefit of treating obstructive sleep apnea for people with chronic risk factors, diabetes, high blood pressure, and other chronic illnesses. So 2 parts: 1, who's appropriate for a sleep study, and 2, what is the benefit of a CPAP for treating obstructive sleep apnea specifically?
So sleep in general, sleep health for all of us should be, as we call it in our discipline, it's a vital sign for your health. Knowing your sleep health is critically important. To me, it's more important than any of the other balance that we do, because there is no body function that does not get affected by sleep. Blood pressure, heart rate, blood sugar, anything that we measure, everything gets affected by sleep. Our appetite, our metabolic regulation. So sleep health evaluation is needed as part of health for everyone. Beyond that, what we call sleep study is an objective assessment of sleep. So those are people that we screen after taking history and examining, when we say there could be a physiological sleep disorder. If someone has snoring, weakness, pause in breathing, if they wake up frequently, they have headache in the morning, they're not rested during the day, if there's memory, daytime, what we call cognitive impairment, concentration, mood change, attention deficit issues. Someone develops high blood pressure in the face of snoring. If there is irregular heartbeat, if there is heart failure, those are the kind of things that we look at and we say, there is physiological sleep problem and we have to objectively study sleep. Or in people with insomnia, when we think there is a lot of cortical awakening, or there is sleep state misperception. What I mean by that is we cannot quantify our sleep when we have insomnia, because the cognitive part of whether we're asleep or not gets disrupted when we have insomnia. So we tend to either over or underestimate. So if I'm trying to use a medication, I have to first objectively assess sleep. So I know which person needs medication, and I know which person does not need medication, but hurts more behavior. When we use medication, when dose need is going up, we objectively measure sleep by home monitoring, so that we avoid the risk of giving higher dose of medication, which will lead to fall or daytime sleepiness, daytime accidents. So that's on a case-by-case basis in general. But sleep health is for everybody. Assessment, sleep tests after evaluation. Now, the sleep apnea and the benefit of sleep apnea is a huge topic. I mean, we can do a separate webinar for that, but sleep apnea leads to oxygen reduction, leads to fragmentation of sleep. Sleep quality gets affected. So what comes next is, as a result of oxygen deprivation, as a result of body producing adrenaline or stress hormone, blood pressure develops, it gets worse, heart is under strain, so left side of the heart becomes thick, right side of the heart develops what we call right-sided heart failure. There's something called pulmonary hypertension, there's pressure between the heart and the lung. There's irregular heartbeat, particularly atrial fibrillation, it tends to perpetuate. There's apnea, there's risk of stroke, and the list goes on. But treatment is positive airway pressure has a positive effect on many of the outcomes, particularly in terms of daytime sleepiness, improvement in blood pressure, this kind of thing. So it definitely makes a huge difference. Also, when we look at sleep, we always look at the family. The spouse sleeps better because husband sleep apnea is treated, this kind of things. I lost you. I can't hear you.
Sorry. For patients who have more chronic insomnia or, a lot of other health issues, if you have diabetes and heart issues, I would recommend probably making a one-on-one appointment with Dr. Mekonnen, and he can decide whether a sleep study is needed or just hear the story out. And then I guess also with the urinary frequency symptoms, I know you had talked about this, but I'm just thinking of common things that keep people awake. If that is something, I would actually start with your primary care doctor, because there are things that you can do to treat people who get up at night frequently to have to use the restroom. And so that, there's sometimes it's a matter of just addressing the root cause of the insomnia rather than treating the insomnia itself. But there's another question here. This is interesting. I've actually heard this before. So a patient said that they had anesthesia for a 4-hour, longer than 4-hour surgery that affected the sleep permanently. One, have you seen this before? And two, what do you suggest?
So, yes, I have seen patients who had prolonged surgeries developing, insomnia. Same thing as people who have sustained some ICU stays, those kind of things. Now, is it the negative exposure that led to subsequent psychophysiological insomnia, or is there a permanent change that has happened? I have not seen in the literature any permanent change, unless there was some vascular event, in which case is somebody develops perioperative event, then yes, sleep would be affected, even development of like sleep apnea in people who have perioperative stroke and other things to follow. But I think it's mostly the negative experience of prolonged procedures and anesthesia, these kind of things. Yes, I've seen it. It takes an event for our sleep to get disrupted. And 4 hours of anesthesia and surgery is a major event.
So do you have any suggestions for that patient who is now unable to sleep post anesthesia exposure?
Yeah, so that would be the type of person that I would go in detail with, clinical history measurement, and that kind of things could be really helped with cognitive behavioral therapy approach. When we know the event that triggers it, and we know how to handle the event that perpetuates the insomnia, in cognitive approach, we have huge, great success. And insomnia, short-term duration related to events, 80-90% improvement in resolution of insomnia could be achieved. So I'll be happy to see that person.
Yeah, and I just want to make a plug here. Yeah, so again, one-on-one visits with Dr. Mekonnen would be helpful if you have specific questions. Also, Dr. Park, who's one of our clinical psychologists, does a lot of sleep training, obviously without medicines, but she does a lot of focusing on the sleep hygiene, the getting ready for bed, turning the light off, avoiding light, same time, routine kind of stuff. And so for those of you who, this is maybe more chronic and you're not really interested in, say, medicine or doing a sleep study at this time, sometimes it's helpful to start with her and see what you think.
We collaborate with, the behavioral psychological aspect of sleep. Our psychologists are very much twinned in, and so we collaborate and work together.
So maybe a more technical question here. How does light from a television screen affect melatonin production?
So good. So light goes through the eye, goes to the retina, and goes to what we call the pineal gland. The pineal gland is this very tiny gland inside the brain. That's where melatonin gets secreted. So light going through that, the electrical signal, prevents the pineal gland from secreting melatonin. If you dim light, you measure melatonin, it goes up. You expose someone to bright light, measure melatonin, it's down. It's because of the pathway from the eye to the retina to the gland that secretes melatonin.
As a female doctor, here's a question that I tend to get a lot because I have mostly female patients. Any tips for insomnia related to menopause? And is there a role for hormone supplements to help with that?
Yeah, so sleep issues in women, tends to come out during the perimenopausal time and menopause and postmenopausal time. Rightly, there is a hormonal influence. So as such, for insomnia reason, hormone replacement is not recommended unless it's needed for some other reason. And when that happens, we see improvement in sleep quality. But the things that we think of, number one, during the perimenopausal time, change in weight happens. When that happens, that's where we see sleep apnea. Sleep apnea in a younger age crowd, it's more common in men, twice as much. Perimenopausal, postmenopausal, it becomes equal. So one is the loss of protection of estrogen, change in the soft palate, and change in weight. So number one is make sure apnea has not developed. So we do the testing. Otherwise, we do the same, usual approach that we do. Sometimes medications are needed, mostly behavioral approach, but hormone as such for its sleep reason is not that.
Okay. All right. So here's another question. When does deep sleep happen, and what is the value of deep sleep?
Good. So when we sleep, we have light sleep, what we call stage 1 sleep. There's stage 2. Stage 3 sleep is what we call deep sleep, because that is quantified by how the brain is acting. When we put electrodes, we see how fast it is. So the faster it is right now, like if I put electrode, there's a high frequency. When we are in deep sleep, the frequency goes down to about 2 to 4 cycles in a second. The brain is very, very slow. Those happens in the first half of the night. There's a difference between that deep sleep and the REM sleep. The REM, commonly known as the rapid eye movement sleep, is a sleep where we dream. Main function is for what we call cortical function, memory, consolidation of events, learning, retrieval, executive function, those kind of things. That comes in a cycle every 2 hours. The more REM sleep is in the second half of the night. So deep sleep more in the first half of the night, REM sleep more in the second half. The deep sleep is extremely important. Most of the things that we see in the body, musculoskeletal effects, say someone wakes up and has aches and pain, like fibromyalgia type of things, that's a function of stage 3 deep sleep. Stage 3 sleep, again, has a lot of hormonal factors. That's where we see many of the good hormones get secreted. So if we're short on that, lots of metabolic things, I'm not feeling good, I'm exhausted, myalgia, aches, pain, inflammatory conditions are seen. So more importantly also, beyond the distribution is, are we getting the appropriate percentage of each of this? When we monitor sleep objectively by our sleep provider, we can see that. We would look into medications that affect sleep states, be it medications that are centrally active, usually medications to treat depression and other psychiatric issues, and other medications as well, like beta blockers and other things. We try to cut off effects of what we do externally, pharmacological sleep state. But when we do sleep restriction methods, we tend to zoom into much deeper stage of sleep, because when we're depriving our body, our brain from sleep, in the recovery phase, we tend to go to more deep sleep. So we have ways to help recover stage 3 sleep, but more of following the normal physiology of our body. There's only one medicine that helps us push to that, that's FDA approved, and that's not used in other circumstances. It's used in narcolepsy setting, and that's Xyrem.
Which medication is the one that helps? I didn't hear that.
Xyrem sodium oxybate, but it's used only in narcolepsy setting.
Oh, okay. Okay. So only narcolepsy. Okay. And then maybe we have a few questions here that I think are a little more personal and related to specific medical issues. So if you have those, please schedule a virtual visit with Dr. Mekonnen, or you can start with either your primary care doctor, to get some initial guidance, or Dr. Stephanie Park, who's our clinical psychologist, who also helps. But If you have a last minute burning question, please submit it now. Otherwise, here's a question. Is it possible to get too much sleep?
Yes, so key things here. We talked about short sleep, but at the same time, long sleep, people who have 9 hours of sleep or require 9 hours of sleep, they also have bad outcome. So there are two conditions here. In nature, genetically, there are short sleepers and long sleepers. What I mean by that is people who don't have any other issues, but they sleep less than 6 hours and they function well. There are also people who sleep 9 hours, 10 hours, and they're fine. So in society, these are in the bell curve on the two ends. There tend to be a lot of familiar cluster with this. So aside from that, somebody who has been sleeping like 8 hours, but now is requiring 9 hours of sleep, we have to look into why that need comes up. Medical conditions do that. Things like Parkinson's disease, centrally acting neurological conditions. The sleep need goes higher, gets fragmented. Light exposure, lack of light tends us to do that. Is there fragmentation of sleep like an apnea event that's happening? The body's need for sleep is now prolonged. So when sleep is getting prolonged, not restorative, that's when we need to evaluate that. Because there is a reason why sleep is not restorative and needing more, but still not restorative. That's excluding the natural short, long sleepers, which have no problem.
Okay. All right. Well, I think that's all we're going to have time for in terms of questions today. Dr. Mekonnen, do you have any last minute words of wisdom or any last thoughts you wanted to be sure to say?
Yeah, so, particularly this time, everybody should focus to getting a good night's sleep, 7+ hours. Whenever you do that, sleep banking always helps you a lot in your daytime, both cortical, mood, anxiety, anything that you name of. So that should be a critical point. Again, remind of fixed wake up time, light exposure at night, half hour before dimming light. And beyond that, if you guys have any issues, I'm always here. We can do virtual visit, we can do evaluation, we do home monitoring in a safe setting, and we will go from there.
All right, thank you. Thank you to everyone who tuned in. Just some last minute announcements for next week. Monday is our COVID update, so please tell your friends, your family, that way they can tune in and you can hear about what Rockville Internal Medicine is doing for COVID at the moment and our current thoughts. Dr. Tannenholz and Christina Schrack, one of our nurse practitioners, are going to do that together. Our first one was very popular. We had about 250 people join that chat, so that was extremely well attended, and we're hoping to get a lot of people out for this one too, so that we can spread a lot of accurate information as opposed to what is on Facebook and sometimes on the news. So we'll see you next week, same time. But thank you, Dr. Mekonnen, for talking today. For those of you who had some trouble hearing, I do apologize. We tried our best there. And if you have any specific questions, feel free to make an appointment with him, and he can definitely go through your insomnia questions, your waking up in the middle of the night, your any concerns you have, and try to address those as best as possible. So thank you to everyone. Have a good weekend, and I'll see you guys here back on Monday. Thank you.
Great.
Thank you.